right. So we're getting ready to start, so if you want to just quickly take your seats, those of you coming in at the back. I'll just give a few moments here. Yep. All set? Okay, I think we'll get started. So I'm Brian Dury, and I'd like to welcome you to this satellite session, Critical Issues Need Answers, Providing Best Options for Myeloma Treatment in 2014. And so we're very pleased to have this opportunity to discuss these issues in a case-based fashion. What I'd like to do first is to introduce the speakers. I'm Brian Dury, as I mentioned. Immediately to my left is Dr. Ola Landgren, who is now at Memorial Sloan Kettering in New York, director of the myeloma program there. To his left, Dr. Vincent Rajkumar from the Mayo Clinic in Rochester, Minnesota. And to his left, Bruno Paiva from the University of Navarra in Pamplona, Spain, having moved from Salamanca. To his left, Dr. Shaji Kumar, also from the Mayo Clinic in Rochester, Minnesota. And last but not least, Antonio Palumbo from Torino, Italy. So we're very, very pleased to have what we think is a stellar faculty to address these questions with you today. So the format is each topic will be discussed in the following fashion. What will be happening in just a moment is I will present a case that will introduce the first topic. And this will include some ARS polling. When you sat down, hopefully you picked up the changer before you sat down. We'll be answering questions on each of these cases. Each case will be discussed pro and con by two of our speakers. Then after each of the cases has been presented, there will be time for some Q&A, and so you can be ready to ask specific questions that you might have. And then before we move on to the next case, we will ask you to answer the question again and see if either one of the speakers changed your vote. So these are the topics that we're going to cover today. So the first one relates to high-risk smoldering myeloma. Should we be treating such patients, yes or no? Then something that is quite topical right now, assessment of minimal residual disease. Should we be doing testing for minimal residual disease, and should we be using that information to guide treatment decisions, yes or no on that one? Then the third question, should continuous therapy be the standard therapeutic approach for myeloma? Should we be using ongoing treatment, or what we've been calling recently fixed duration therapy after some type of maximum response has been achieved? And then finally, a question about relapse patients, salvage therapy. What is the preferred approach to the management of patients in the relapse setting? So let's get started with the first case. Should therapy be initiated for high-risk smoldering myeloma, yes or no? The presenters for this topic will be Dr. Ola Landgren, followed by Vincent Rajkumar. The case that will form the basis for this discussion is coming up now. The case is a patient that is identified as having high-risk smoldering myeloma. This is a 62-year-old gentleman with an M component, 2.5 grams, IgA kappa. The free kappa level is 190 with a lambda of 10, a ratio of 19. This particular patient had no CRAB features, including normal calcium, normal serum creatinine, no anemia, and no evident bone lesions. A bone marrow did show 30% plasma cells. The FISH testing showed translocation 414. MRI of the spine showed no focal lesions. So, we've given you 4 choices here as to how you would approach this in your clinical practice. So if you can go ahead and answer this question, would you initiate therapy with lenalidomide dex, consider a 3-drug regimen with carfilzomib, lenalidomide dex, or would you observe this patient or consider assessment for entry into a clinical trial, or at this point are you unsure? So 1, 2, 3, or 4. All right. Okay, so the debaters can look at this. So a significant majority would go with number 3 with no clear answer to observe or consider a clinical trial. But about a quarter of you would consider going ahead with Landex. Only 5% of you are unsure, which is also quite interesting. So with this as a starting point, Ola, I would invite you to come up and make your case for considering therapy. Please welcome Dr. Ola Landgren.
Thank you very much for those kind words, Brian. I'd like to thank the organizers for inviting me here today. So I've been given the task to argue for yes. So I put together slides where I try to use data from selected studies to provide a yes. But I was thinking maybe I will help Dr. Rajkumar also a little bit. So I thought maybe I start off by saying no. So I'm going to just show one slide, and I will hopefully tell you that you shouldn't vote for that later. And then I will tell you about something a little bit efficacious, and then I will try even harder in terms of treating these patients. That's going to be 2 and 3. So for number 1, this is what you're going to hear from Dr. Rajkumar. But I will also like to draw your attention to this slide, which comes from the Mayo Clinic, as you know, showing that high-risk smaller myeloma is really not a good thing to have. It's actually very bad. You're very likely to develop multiple myeloma. It takes less than 2 years on average if you have the high-risk features. And as a further background for this argument, and I think this is important, and the case Brian just presented, I think when we discuss this afterwards, highlights the fact that at this moment there are different ways of calling a patient high-risk smoldering myeloma with regard to transforming into clinical multiple myeloma. These are 7 published models in the literature. There's a Mayo model, there's a Spanish model, and there are FISH models, there are imaging models, there are plasma cell labeling index models, and there are the model from the New England Journal from last year. So there is not one model out there. There are very many different models. Depending on which you believe in, you could call it high risk or low risk. Okay, so to do something, to do a 2-drug combination, this is from the New England Journal of Medicine publication in 2013, first author Maria Mateos from Spain, using the type of therapy that many of us would use for newly diagnosed patients of certain types of disease, using Revlimid 25 milligrams day 1 to 21 on a 4-week schedule together with low-dose dex, and they gave that for 9 cycles on the left in blue, followed by 2 years of maintenance with 10 milligrams of lenalidomide. And on the right, they followed these patients. There were 60 patients in each of the two arms, and they were all high-risk smoldering per definition in this paper only. This definition has not been used in any other papers. It's quite similar to a merge of the Mayo Clinic and the Spanish models. So just to highlight a few things from this very publication, 14% of the patients reached a complete response using the criteria we have for multiple myeloma. And as you're aware, there are no response criteria for smoldering myeloma, but using those criteria that we have for multiple myeloma, 14% of patients reached that after completion of the 9 cycles with Revlimid dexamethasone. If you look across the board and then you move to the right, you see that after maintenance therapy, that 14% went up to 26%, showing that if you continue with therapy, the response will keep on going and more patients will go into deeper responses. To focus on the outcomes, the study was designed to look at progression-free survival as the primary endpoint, and in blue here you see those patients treated. And you see that you have not reached the time to progression, the median time to progression, while for the patients that were only followed, the median time was only 21 months in red. And this is, of course, highly statistically significant. Looking at overall survival, which also was done in this study, again, there is a difference between the two groups, and you see the p-value is 0.03, and you have the details. There are, of course, a lot of comments that could be made regarding this study, and in the interest of time, I'm not going to go into it, but I think the data are the data, and they show that starting earlier will delay disease progression, and we can have discussion about overall survival and comment the study maybe later. So the other option would be to pick some other even more potent therapies, and I picked, to just illustrate this example, using the same backbone I just presented and adding a third drug. And this is the study that we did when I used to work at the NIH. It's not yet published, this study. So we used a 3-drug combination, so Revlimid dexamethasone, same dosing schedule, but adding a third drug, which in this study was the carfilzomib drug, the proteasome inhibitor of 20S proteasome. So this study had these 3 drugs, and the carfilzomib drug was given 20 milligrams per meter square, the first 2 doses, followed by 36 milligrams per meter square, all subsequent doses. It was given for 8 cycles, and after 8 cycles were given, 2 years of maintenance was given. So it's very similar to what I showed you in the previous study here from Spain. This is not yet published, but it's presented here at a meeting. As you can see on this slide, patients have a very high response rate. And in yellow, you have the near complete response, the complete response, and the stringent complete response. On the very left, it says BL, that stands for baseline, and then 2, 4, 6, and 8 cycles. And at 8 cycles, all the patients reach a complete response. And you may think that we already knew this before this study was done, and I think that's probably a true statement, but I think it's still interesting to have the results. Now, what did it show in terms of toxicity? Well, when you give these potent drugs, of course, you have a lot of toxicities also. The toxicities are similar to what has been reported with this triple drug combination for newly diagnosed patients. And I think this is very important to consider when we give potent drugs, that there are toxicities. We are presenting it here at the meeting, and it's going to be presented on Monday at poster 4746. So I won't show all the details here at this presentation, but I can tell you that the results show impressive deep responses. Minimal residual disease has been evaluated both by flow cytometry and next-generation sequencing, as well as molecular imaging. And there is also longitudinal minimal residual disease testing in this study, showing that almost every patient reaches this MRD negative state. So to summarize my presentation, should therapy be initiated for high-risk smoldering? I was given the task yes, so I decided to add another explanation here on a clinical trial. I do not think we should do it outside trials, but I do think the answer is yes. And with that, I would like to remind you that you're going to hear Dr. Rajkumar talking about the left topic, and then afterwards we will hear if you have changed your opinion about treatment. Thank you very much for your attention.
Thank you so much, Ola. So I'd like to welcome Vincent to argue no.
Actually, a couple of things. Ola has already lost the debate because he said he would not treat patients outside of a trial, which is what I want you to go back with as the take-home message. Thank you. Secondly, he said that you have to do something to get paid. I think he's thinking of some other profession. Because they pay me to decide who to treat and who not to treat. And they pay me to decide when to treat and when not to treat. So before I start, there's been a major change to the myeloma diagnostic criteria, so that I just want to highlight. The previous disease definition for smoldering myeloma is patients with more than 10% plasma cells or an M spike 3 grams or higher without CRAB lesions. Patients with myeloma needed to have CRAB. And MGUS is differentiated from smoldering in that you need to have less than 10% and less than 3 grams. And the reason we wanted to split MGUS from smoldering myeloma, even though both of them are pre-malignant, is that a MGUS patient can be reassured that it's a risk of progression of 1% per year. So 10 years go by, there's only a 10% chance that they will get myeloma, and a 90% chance that they won't get myeloma. On the other hand, smoldering myeloma is a different bag of fish. Here you can see that there is a 10% per year risk of progression over the first 5 years. After the 5 years, it actually slows down to about 3% per year. And if a patient with smoldering myeloma has gone on for 10 years, then the risk actually drops to like MGUS, 1% per year. This happens because smoldering myeloma is not a biologic entity. It is a mixture of some patients who have myeloma, who have not yet declared themselves, and some patients who have MGUS. As time goes on, the myeloma patients declare themselves with end organ damage, and after 10 years have gone by, what you're left with is a pool of patients who have just MGUS. Now, we have been very concerned about people with smoldering myeloma, particularly those who progress in the first 2 years. If you have if you have an 80% chance of progressing within the first 2 years, those patients don't really get any benefit by watching. In fact, they can be harmed because you're going to get renal failure or bone lesions. So that is one of the reasons why the diagnostic criteria have been updated to include biomarkers such as plasma cell percentage more than 60%, so that if you have something like that, even if you don't have any end organ damage, no CRAB, the progression happens so fast, half of the patients have progressed within a few months, and 80 to 90% have progressed within 2 years. So the revised myeloma diagnostic criteria has included, other than CRAB, patients with 60% or more plasma cells, free light chain ratio of 100 or more, and more than one focal lesion on MRI as being equivalent of myeloma. By doing that, automatically we have reduced the risk of progression in smoldering myeloma. And smoldering myeloma has become a slightly different entity. You need to be 10 to 60% plasma cells and none of these myeloma-defining events. So this is exactly what we have done. We have still got smoldering myeloma, but this small segment that we used to call smoldering is now called myeloma. The debate is not whether to treat these patients or not. We should. That's now myeloma. The debate is not whether we should watch these patients or not. We should watch them because the risk of progression in this group is probably 5% per year. The real debate is what to do with this group, and that is the case that we have today. This patient is high risk because of three reasons. The patient has a 414 translocation, IgA, as well as a free light chain ratio of 19. Anything more than 8 is high risk. If you take any one of these three factors, the risk of progression is not 10% per year, it is 25% per year. So when I say high-risk smoldering myeloma, I mean a median time to progression of 2 years. The debate here is, should you treat these patients outside of a trial, or should you just observe them or try to consider enrollment in a clinical trial? So here are the risk factors this is how all of these have been studied in one or more studies and found to have a median time to progression of 2 years. I would consider a patient who has any one of these factors as having high-risk smoldering myeloma. So what should we do with this group? The argument that Dr. Landgren made is that we have a study that now shows there's an overall survival advantage with lenalidomide and low-dose dexamethasone for patients with high-risk smoldering myeloma. This was the survival that is improved compared to observation. So why am I saying no? Number one, that study is not generalizable to the vast majority of the world. They used a definition of high risk, which is not easy to do for most people. Second, the sample size of that study is very small, so that the number of, the whole overall survival difference that you saw is based on a very few number of deaths. 4 deaths in the treatment group versus 13 deaths in the observation group. I must add that there is also an age difference, a significant age difference between the placebo or the observation arm and the treatment arm in this trial. The third is, even if you wanted to do lenalidomide, except in the United States, most other places you cannot, because it's not approved and will not be approved based on that trial, since it did not isolate the effect of lenalidomide. So you didn't know whether it was the dexamethasone that saved lives or lenalidomide or both. And that kind of isolation is required for a regulatory authority to approve. So there's a trial going on right now in the US that I'll encourage people to participate in, looking at lenalidomide versus observation. And the fourth reason, which is the most important, is that one of the main pressures why we wanted to treat smoldering has been reduced by the updated criteria. The updated criteria now allow you to start therapy for a high-risk smoldering myeloma patient before CRAB occurs, based on the 3 biomarkers that I mentioned, the bone marrow plasma cell percentage, the free light chain ratio, and the MRI. In addition, the criteria also recommend monitoring changes. You can monitor your patients with CTs, PET CTs, MRIs, so that you don't have to wait for the pathologic fracture. Same way, by monitoring patients with free light chain levels and ratios, you can prevent the renal failure by initiating therapy before the creatinine goes up. I think that has mitigated the immediate need and allowed us to say, let's take a deep breath and wait for clinical trials to show that we are actually doing some clinical benefit. Because after all, every treatment that we do has a side effect. I mean, there are patients who can actually be harmed by the fact that we initiated therapy, because this is an asymptomatic population. Half of them could have gone on for more than 5 years without any kind of progression. I did not go into the carfilzomib Lendex trial because I'm sure Dr. Landgren would agree that with a small study of 12 patients showing CR, it's really only a hypothesis at this point. So my recommendation is there is no more ultra-high-risk smoldering myeloma, that's myeloma. For low-risk smoldering myeloma patients, I would observe, and for the high-risk smoldering myeloma patients, I would observe or enroll them preferably in clinical trials. Before I close, I just want to say that, listen, the best treatment the best payment for a physician is seeing your patients do well. So I would agree with Dr. Landgren. I would rather get paid doing nothing.
All right, thank you to you both. Before we ask you the question again to see if any of you changed your opinion, do we have any questions or comments or thoughts from the audience? Anyone have anything they'd like to say? Any of our panelists like to add their 10 cents to what we've heard?
Actually, both agree because they both saying that outside clinical trial, there is no treatment. So the debate was not really a good debate.
So any of our panelists feel strongly? So Ola, you feel that outside of a clinical trial, do you treat?
I do not treat patients with smoldering myeloma outside clinical trials at this very moment. I think in the future it could become the way we do it, and I think that's probably the way it's going to happen. But I think there are so many questions that we need to answer first. How do we define high risk, and which is the best way of treating, and how shall we monitor? And because these patients are asymptomatic and we are dealing with drugs that can cause harm, I think it's not responsible as a clinician to give it outside a trial at this point. That's my personal take.
All right.
Yeah,
So.
if I can, I think I would make 2 considerations. The first is there's probably needed more research to clearly define the biomarker that defines myeloma versus MGUS, and define malignant disease versus benign disease. And on the other hand, from a clinical point of view, what is not today taken in consideration is the kinetic of growth of the M component. In other words, within a benign malignancy, like could be a smoldering myeloma, if I have an M component that is doubling in less than 2 months or in a very short period of time, this is probably an alert that the myeloma is coming pretty soon.
Yeah, good point.
I think I just want to make the point that what is left kind of unsaid between the two debates is that there's a paradigm shift in our approach to these patients. These patients whom we were hesitant in treating before, and now we are not waiting for something bad to happen, but if we have reliable way of assessing something bad is going to happen, we are willing to treat these patients. I think that is a paradigm shift in the thinking about this disease.
Yeah, I think that this is really a key point. Vincent, you want to comment?
Yeah. This is a very, very hard question. Dr. Landgren and myself and Dr. Mateos have written a paper that will come out shortly on how to approach this high-risk smoldering myeloma. And it's a very, very difficult problem, particularly if you have a patient like this where the M spike is actually rising, or who has multiple high-risk factors, let's say circulating plasma cells. It's something that we have to really think about. I think it's important that the trials get done fast, but it's not an easy answer. Dr. Blade has an abstract at this meeting looking at the kinetics of the M spike and showing which kind of patients may merit, earlier consideration for therapy, and getting that validated and published would also be important.
Yeah. So studying that biology is really key. Okay, so let's go forward and ask the question one more time and just see where we are with this. So the case is still the case. It's a patient with high-risk smoldering, as identified by Vincent, with the IgA, with the abnormal free light, with the 414. So, any change? How do you vote now? Okay, suspense. Oh, okay, so the previous readings are on your right. So number 3 was 60%, and so now it's 77%. Okay, so still not 100%, so that 17% are still favoring Landex. We only have 1% unsure now, so this is maybe an improvement, a 4% improvement on that. But still very, very few would want to use the CRD at this point in time. Okay, so thank you for that. So let's move forward to the next question. And so at ASH this year, if you check your program, you'll see that there really are a lot of oral sessions and posters dealing with the measurement of minimal residual disease. And so this is a particularly topical question. Should we be starting to look at MRD to guide treatment decisions, yes or no? And so to help us with this, we do have a case where MRD testing was performed. And so this is a lady, a 50-year-old lady with newly diagnosed myeloma, received 4 cycles of the CyBOR-D regimen, bortezomib, cyclophosphamide, and dex, achieved a partial response. There were abnormal chromosomes, multiple trisomies, amplification of 1q, deletion 17p. The patient received an autologous stem cell transplant, but continued to have a response at the PR level. At that point, maintenance was given using lenalidomide, and after 1 year of the lenalidomide maintenance, the patient did achieve a CR. At this point, it was decided to do a bone marrow and perform MRD testing. And you can have your choice, actually. We give the choice whether you would use the molecular sequenta method or a next generation flow method, the high sensitivity flow method. And so that testing was negative. So this is a patient who had ultimately achieved a CR and then was MRD negative in the bone marrow. So the question is, how would you use this information? If you have an MRD negative test, would that mean, okay, you would stop the maintenance therapy? Would you continue with maintenance therapy? Would you request some additional testing, or would you be unsure what to do? So consider your answer to this. All right, so let's see where we are with MRD. Oh, okay. So fairly evenly split between stopping and continuing. A few wanted to get a PET CT. Only 7% are unsure. Let me check here. I think we may have had one additional question here. Is there another question that you have right now? All right. Can we move forward? Oh, well. So the debaters for this topic are Dr. Bruno Paiva and Dr. Shaji Kumar. And so Dr. Bruno Paiva will be discussing the reasons that why one might consider using that MRD testing to make a clinical decision. So, oh, okay. For some reason, we don't have Bruno's introductory slide. I'm sorry for that. But this is your first slide, Bruno. So please welcome Bruno to present on the use of MRD testing.
First, I would like to thank Dr. Duri for giving us the opportunity to present our arguments. And let's make things very clear. The focus of the debate is not about maintenance, whether maintenance has no efficacy in myeloma, whether maintenance is effective in all patients, or if maintenance is effective in a subset of patients, but we don't know yet how to prospectively identify such patients. The focus of the debate is on MRD and if MRD can be used to guide treatment decisions. And here, let me start by saying that we fully agree with Dr. Kumar and his team when they stress the importance of bone marrow evaluation to define CR, either by conventional microscopy, either by immunohistochemistry. But I'm sure Dr. Kumar would agree that the method to define clonality on the tree-fine biopsy using the Kaplan-Lander ratio is rather suboptimal. For example, for a lambda patient, even if 30 out of 100 plasma cells are clonal, the Kaplan-Lander ratio would still be normal. So let's talk about true MRD detection to monitor treatment efficacy. And let me present you 7 facts supporting the value of sensitive bone marrow evaluation. First, patients in CR after high-dose chemo with persistent MRD, even though detected by less sensitive four-color flow, that would be the yellow curve, have similar outcomes as compared to patients in near CR or partial response. Second, MRD kinetics discriminate chemosensitive patients, MRD negative before and after transplant, median TTP of 9 years, from chemo-resistant patients, MRD positive before and after transplant, median TTP of 3 years. This means a 6-year difference in time to progression. Third, CR after consolidation without MRD eradication translates into significantly inferior PFS as well as overall survival. Fourth, maintenance improves PFS of MRD-positive patients after stem cell transplantation, and this is because a subset of those patients turn from MRD-positive into MRD-negative. Now, let's focus on MRD-negative patients receiving maintenance. That would be the red curve, and MRD-negative patients that do not receive maintenance. That would be the orange curve. There's a difference, which means that less sensitive MRD monitoring before maintenance should not be used to guide treatment decisions. But then again, Dr. Kumar, that is not the patient case. Fifth, the impact of MRD negativity on patients with high-risk myeloma. That would be the blue curve. Time to progression and overall survival become very similar as compared to patients with standard risk cytogenetics. Six, and this is very important, why do some patients who achieve CR relapse early on and on top of that have a dismal overall survival? In other words, the concept of unsustained CR. The best way to prospectively identify patients with unsustained CR is by combining the information of risk stratification by cytogenetics at diagnosis plus MRD monitoring after treatment. Even though the patient is in CR, if the patient has high-risk cytogenetics at baseline plus persistent MRD after therapy, median TTP is half a year and median overall survival of only 2 years. 7, and because this debate is not really new, we already had this debate for CR, so we already know what the arguments will be. There's always the argument that the depth of response is of no value among biologically favorable patient subgroups. Well, that could be the case for CR, but keep in mind that here we are talking about MRD, and MRD is a completely different story, is more sensitive. And here you can see the outcome of MGUS-like myeloma patients achieving MRD negativity. With a median follow-up that exceeds now more than 5 years, time to progression as well as overall survival are in the range of 80%, even though maintenance therapy was stopped 3 years after the MRD assessment. Now, do we have better than less sensitive four-color flow? The answer is yes. We now have multidimensional, highly sensitive flow, and this is the promising data coming from the French group. We also have NGS-based MRD monitoring, and this is the promising data coming from the Spanish group. And we also have PET-CT to evaluate the quality of CR, and this, I would say, is very important data coming from the Italian group. And I would say also that the quest for 2015 would really be how to best conjugate intramedullary and extramedullary MRD techniques. Now, Dr. Kumar will tell us that there is no consensus, but here I clearly differ because, in fact, we are working together to develop a consensus next generation flow MRD approach, a method that not only allows a standardized and automated classification of a plasma cell into normal or myeloma, but also allows the analysis of the B-cell compartment, the recovery of the B-cell compartment after therapy, which might be important to identify those patients that, despite not achieving deep levels of remission, will show nevertheless long-term outcomes, and certainly a method that allows the measurement of other cell populations in the marrow to assess the quality of the sample. On that, I would fully agree. Why to bother to do the MRD test if first you don't assess the quality of the sample and see if there is or not high peripheral blood contamination? Finally, I would like to quote Dr. Kumar's words. A major step for researchers moving forward is to determine for how long maintenance therapy should be given. Dr. Kumar, we fully agree with you, and we believe that the way to move forward is by addressing this question using MRD within the scope of clinical trials. Not after induction, not after high-dose chemo, not after consolidation, not before maintenance, but after a fixed period of maintenance, randomizing the patients into further maintenance if the patient was MRD positive or no maintenance if the patient were MRD negative, and also after serial MRD monitoring, paying particular attention to follow-up analysis, giving the emergent data showing that an MRD reappearance translates into a clinical relapse. So for sure, Dr. Kumar agrees. How could you not agree that MRD evaluation will contribute to both a better definition of response and to monitor the efficacy of intensification and maintenance therapies? And I would also say that Dr. Kumar will agree that the time has come to implement MRD in clinical trials and to see if MRD could be of value for tailored therapy and most importantly to avoid both under and over treatment of myeloma patients. Thank you for your attention.
All right, the value of MRD testing. So, all right. I don't know why these are a little messed up, excuse me. So please welcome Dr. Shaji Kumar, will tell us that we should not be paying any attention to the MRD testing for now, okay? Welcome, Shaji.
Thanks, Brian. I think the answer to the question is very simple. Of course not. But first of all, let's start by congratulating Dr. Paiva for a very good job in convincing us that MRD negativity is a very powerful prognostic factor in multiple myeloma. A round of applause to Dr. Paiva. However, I think he's gotten it completely wrong. So the question is MRD relevant in multiple myeloma? It's a very nuanced question. It all hinges on how do you define relevance. Now, this is not a new debate. I think we have been debating this question ever since we have had any effective treatment for multiple myeloma. The question has been asked in various different forms, but the essential question is, does depth of response matter in multiple myeloma? The previous debate was whether complete response was needed or not, but now that we have all sorts of fancy tools, we have changed that question to say, is MRD relevant in myeloma or not? Now, as you can see in this slide, if you actually get patients to have a deep response, it'll take some time for the clone to grow back. You get it deeper, it'll take even more time. Take it even down, it takes even more time to actually, for the disease clone to grow back, and hence the progression-free survival is going to be longer. The most important question we had to ask is there a threshold for response depth beyond which the clone just cannot grow back up? And that is what we are all aiming for, the ultimate cure for this disease. And that is also very important because the entire debate about MRD testing should be built around not progression-free survival. Those curves will always look great. It should all be built around whether it improves overall survival in this disease. Now, as you already heard, it's a powerful prognostic factor. If you have a bunch of patients who are MRD negative after whatever they got or no treatment, those patients are always going to do better than the patients who still have residual disease left. That is as a group of patients. It doesn't tell you what you need to do about the individual patient. So why is there so much of heterogeneity about this whole concept of difference in the PFS and the impact on the overall survival? That is because we cannot take the question of minimal residual disease negativity in isolation. It has to be taken in the context of disease biology. It has to be taken in the context of the effectiveness of therapy that we are giving this patient. And most importantly, kind of the hidden thing in this whole picture is the toxicity that we inflict on the patient by intensifying our therapy. So as the disease becomes less aggressive and we have more effective therapy, there's going to be increasing survival in this patient. So let's first take a look at the biology. Now, you already saw some of the slides before. On the left-hand side is data from the University of Arkansas, where patients who have low-risk disease by gene expression profiling, Dr. Barlagi was able to show that the achievement of CR really didn't make a difference to those patients. On the bottom are the patients who are high risk by gene expression profiling, where clearly achievement of CR was associated with a better overall survival for these patients. On the right-hand side is data from Dr. Paiva, which again shows that if you have a standard risk fish and if you are MRD negative, you do the best. However, if you have either a high risk fish or you have MRD positivity, you kind of do in between. And if you have both, then you actually do very badly. And clearly, this tells you that you had to interpret the MRD testing results in the context of disease biology. Now, the whole debate today is not about the prognostic value of MRD testing. It is about how do you guide your treatment using the MRD testing. So that brings up two questions. How are you going to decide on your therapy in the beginning? Is your goal going to be MRD negativity? And are you going to do anything different if you actually don't get to your MRD negativity's phase? Now, clearly, the therapies have moved on, and we have very effective therapies which can give you upwards of 60, 70, 80% very good partial response in this disease. Does that automatically mean that we go for the most intense regimen that we have in our toolbox? Not necessarily. On the right-hand side is one of many examples where we have used intense therapies and have shown that there is a significant improvement in the progression-free survival. But here, Dr. Rossignol was not able to show a difference in the overall survival, irrespective of whether she used a thalidomide dexamethasone combination, bortezomib thalidomide dexamethasone combination, or a multiple chemotherapy combination. So just because we have an effective tool doesn't mean we have to use it, because it all hinges on how you define the effectiveness. The next thing is, if you don't reach that MRD negativity or whatever degree of response that you think is the best for the patient, are you going to change therapy? There are arguments for and against that. If you look on the left-hand side, this is the result from the double transplant trial, where clearly Dr. Attal was able to show that the benefit of a double transplant was restricted to patients who did not get a very good partial response with the first autologous peripheral blood stem cell transplant. On the right-hand side is an analysis from the CA-BMTR data looking at thousands of patients who underwent induction therapy prior to autologous stem cell transplant. And what Dr. Witch was able to show was that irrespective, even if you don't get a partial response with your initial induction therapy, and you went ahead and changed and gave them some other salvage therapy, it did not make any difference at the end of the day after they went through the autologous stem cell transplantation. So clearly opposing views in terms of whether we should act upon the depth of response result after a particular therapy. Now, you could argue that's all because it's a complete response, and we have moved on, and we are just talking about MRD testing. So this is more recent data from the UK, and on the left-hand side is the progression-free survival for patients at the bottom. Here are the patients who were MRD positive at the end of induction and MRD positivity at the end of transplant. In the middle are the patients who were positive at the end of induction but became negative from the transplant. And on the top, you see people who were negative at both phases. Looks impressive. As you gave transplant and made them negative, they had a better progression-free survival. But the real proof lies in this one, where you can see that patients who actually were negative at the end of, positive at the end of induction and was made negative by high-dose therapy versus the others, there's really not much of a difference there. How about now to make the things more complicated, the kinetics of response is another factor that we have to think about when we make treatment decisions. On the left-hand side, you have the data from the total therapy trial, where it was shown that if you have a very rapid response in the form of the light chain response, you actually do worse compared to patients who actually had a relatively slower rate of response. So when do you actually do your MRD testing? Do you do it the very first time you get the complete response? What about the patients who get a complete response after 2 months versus somebody who gets a complete response after 1 year? On the right-hand side is, again, data showing that if you actually get complete response and you lose the complete response very fast, those patients actually are the ones who do worst. So what does that mean? You have to keep doing your MRD testing like every other month. I can't think of a better way to drive your patients away. So, but you also have to think about all this in the context of the toxicity of therapy. Now, on the left-hand side is a real eye-opener from the thalidomide maintenance trial that Dr. Stewart did. And even though the thalidomide maintenance really did not show any improvement in the overall survival, the quality of life analysis clearly showed that there is a worsening quality of life metrics as patients were on thalidomide maintenance. Now, it's not just the quality of life. There's also an increasing risk of second primary malignancies, and even other than the second primary malignancies, there's increasing risk of cytogenetic abnormalities in the bone marrow of patients who are on lenalidomide maintenance, for example, from this study from Arkansas. So clearly, there's a price to pay when you intensify therapy looking for that elusive goal of MRD negativity. Now, if those problems weren't enough, we really don't have a consensus, despite what Dr. Paiva said about how we should do MRD testing. He admitted that the flow testing is still a work in progress, so I think clearly that means we are not there yet. We have to first get to the consensus before we can use these approaches. Now, the other big problem is we only look at the bone marrow and we say it's clean. That doesn't mean that there's not going to be tumor cells outside the bone marrow. We know that extramedullary disease is increasingly being encountered in the clinic as a frequent form of relapse. We don't look at the normalization of the immune compartment, which is also relevant. Now, again, one of the fallacies of the MRD testing is it is meaningless in isolation. Take a look at this example where you actually have patients who are not in a CR, but they're still MRD negative. Now, what does that mean? We are talking about depth of response, and it again tells you the fallacy of just looking at the bone marrow and saying that somebody is MRD negative. So I think the answer is very clear. MRD testing today should not be used to guide the therapy of the patient that you are taking care of. It is a wonderful tool that should be studied in clinical trials. We do not know who benefits the most from MRD, the biology question. We do not know the most effective and the least toxic therapy that we can utilize to get a patient into an MRD. We do not know if changing therapy based on the MRD testing will actually alter the survival of these patients. And we don't even know how and when to assess the MRD. So clearly a lot needs to be learned about MRD testing, and as Dr. Paiva clearly pointed out, it should only be done in the clinical trials, and that is the only point I would agree with him. And thank you.
Okay, so very decisive points there from Dr. Kumar. Bruno, do you have any immediate retort to this? What would you like to say? We could get this mic on, yeah. Go ahead.
I would say that we might agree in more than one point. I actually thought you were doing very well, but on the very last slides, you lost. Because you mentioned a point that I clearly understand, the toxicity regarding therapy. And my question is, how do you balance and how do you decide, and whether or not you think that having this information will be useful for you to take the decisions?
Yeah, the other point I would agree with you is that design of the clinical trial. I think that is that you saved me one slide not having to put that in there. So.
Okay, so anybody in the audience who wants to talk about MRD? Are you doing MRD? You're not doing MRD? You want to do MRD? Very quiet today. Any questions back there? No? All right. Any other comment? You have a question here? Okay. Go to there's a microphone right behind you.
So my question is, if MRD is negative, we know relapse will take longer, maybe 7 years, 10 years. And definitely we need to decide, do we keep those patients on maintenance for that long or not? So I think we should take that into account. Do we push for more maintenance therapy for 7 years, 10 years? You made it in your slide clear that maintenance is toxic. Drugs are toxic in general, and we shouldn't use that MRD negativity to be less likely to push for that maintenance for many years.
Yeah, so I think this is a good point. So in this case, actually, the patient was on maintenance and became MRD negative. Couldn't that be useful to decide to stop the maintenance? What do you think? Vincent? Vincent might stop the maintenance anyway, but no.
That's a great question. So, you know, the major
thing that I got from both talks. Both speakers had like fantastic data that you spent a lot of time analyzing literature to come up with the points that you made. Clearly, it's a powerful prognostic tool. So if you have it and you already have the result, then you are able to reassure the patient that they'll have a better prognosis. And clearly, whether you do it or not usually will be resolved in time. But the question is whether you act on that result and do something about it, either to stop maintenance or not, or to continue maintenance or not. I think those are the main message is we don't know. We just do not have any data on how to use the result wisely. We may do something, but that doesn't mean we are wise about doing that. And thankfully, there are clinical trials being designed to answer exactly the question that you raised. If the MRD is positive after a course of therapy, should that determine the duration of maintenance? Should that determine what kind of maintenance you use, and so on? The trials are being developed in the US, in Europe. I know Salamanca has already designed a trial like that for smoldering. So it's happening.
So,
But if I can,
yeah, Antonio? Yes.
It was probably raising a different issue, and of course I'm biased in my answer. But you were mainly saying if I have a remission that is keep going 7 years, should I keep going 7 years? Because now the remission might be pretty long. My answer is, from an efficacy point of view, and we will discuss in a moment, yes. From a toxicity point of view, maybe, because certainly the drug we do have today were not really so clean of any toxicity, so 7 years of a prolonged treatment might create some trouble in terms of toxicity. So my answer would be yes, in terms of efficacy, because myeloma to some extent is no different from CML, and Gleevec, when you stop at Gleevec, the disease is coming back, and more or less we are facing the same model. Probably no, if this is creating toxicities, because we do not have drugs currently so rid of any toxicities that you can reach this length. Different is 2-3 years, that's a different story.
So,
But
thank you.
if I can, I would also ask a question to the panel.
All right.
Would you stop treatment, let's say, after 6 courses of induction when you do the bone marrow, MRD is negative, starting from Ola?
No, I would not stop based on that. I would not stop.
Vincent?
I would wait for the debate to end. I don't want to beat you already. I'll give you 15 minutes before I...
Yes, he's getting extra time for his debate. So Ola, do you want to comment on this MRD point?
Yeah, so I agree with what the other speakers have said. I was thinking maybe a few things that I think need to be added to this discussion is that there are different ways of doing MRD. We heard from the speakers talking about flow cytometry, and you can use ASO PCR, where you can amplify from the VDJ sequence in the tumor cells. You can do next generation sequencing. You can do different types of technologies, cell-based, molecular-based. You can also do imaging, of course. You can do sophisticated PET-CTs with maybe newer tracers. I think the field is moving very fast forward, but at this point, we really don't know which method that's the best. And there are questions also, when is the right time to do this workup? Is it around the time of CR, or is it to do it as a prognostic test, do it early on and quantify instead of saying positive, negative, to look at the number of whatever units you have. So there are so many of these questions that we don't know the answer to. So I completely agree with the other speakers that more work is needed in clinical trials before we roll it out. If we all start ordering all these tests right now, it's going to be very difficult, it's going to be very expensive, we are just going to be confused.
Bruno.
Yeah, well, before I make my thoughts, just to address Antonio's question, certainly, and all the data is really telling you that a single assessment or a single snapshot is not enough, and you need serial information to have a bigger picture of how the patient will likely behave. And secondly...
But let's say you confirm MRD in a subsequent test.
Well, Preliminary data with, I would say, relatively short follow-up using the more sensitive tools. We are seeing that patients with, let's say, for example, 3 time points with an MRD negativity have a stable PFS in the short term of around 100%. That's very promising, but that's still very preliminary. I would say that even though we are debating, this is the natural course how things are supposed to be. First, you need to show added value, and I would say that many different groups have shown there is added value, and then you need to implement. And then only by seeing evidence and data on randomized trials, you can actually take decisions. I would say that's the same story for a drug. You need the drug to show superiority in a trial.
Okay, thank you. We have time, it looks like, for one question right here. Please go ahead.
I just want, François Guillot from France, I just want to go back to the fascinating situation of patients with the restoration of the immune system and the MRD patients. I'm saying this because in the CML situation, patients who have been treated with Gleevec, who stopped the treatment, there are 2 groups of patients, in fact. Those are the patients who do not relapse because there is a restoration of the NK systems, and patients who relapse because there is no restoration of the immune system. So I was very pleased to hear that, in fact, in the myeloma patients, might be 2 subgroups of patients with some restoration of the immune system who may play a role keeping these patients in the situation in which there is no risk of recurrence of the disease.
Yeah, thank you. Thank you. This is a very important point. And I think actually both speakers mentioned that this assessment of the immune system could be part of what we need to learn more about. Okay, so thank you. So before we move on, let's ask the question one more time. So what do you think? This is the case. It's a patient who did achieve CR after 1 year of maintenance with lenalidomide. MRD was negative at that point. Stop, continue, additional testing, unsure. Okay. All right, well, I don't know, maybe we could have skipped those presentations, I don't know.
The debate was very informative.
Yes, people are still split. Now, we actually have a follow-up question here which might help clarify this. Sorry, let me go back. So when you made this choice, was it in any way influenced by MRD, or was it based upon your feelings about maintenance anyway, independent of MRD? So was it based on MRD information, or was it based on something else? Yes or no? No. Okay. So most people were not paying attention to the MRD testing. All right. Well, it was certainly very, very informative, and actually, I think for the future we're going to be learning a lot more. So let's go to the next topic, which links in pretty closely. Should continuous therapy be the standard therapy in myeloma? Yes or no? And we have, for this particular debate, 2 people who feel, I think, quite firmly about their answers. And so we'll start with Antonio, who will persuade us yes. Oh, sorry, we'll do the question first, I'm sorry. So the case in this instance is it's a 70-year-old gentleman who had translocation 1114 and Started off with Velcade, Revlimid, and Dex. After 6 months, went into a complete remission. At that point, and this links to a question you were just asked, was switched over to lenalidomide maintenance and was continued on for 1 year. And so for this patient who has achieved a response and then maintained on lenalidomide, would you continue with that maintenance therapy, or would you stop, or are you unsure? All right, so 60% actually would continue with the Revlimid maintenance in this case. Only a few people are unsure. All right, so Antonio, you want to take us through why those 60% are correct or not?
Okay, we now move to the maintenance and to the continuous treatment. These are my disclosure, and of course, thank you for the invitations. The first issue I would like to highlight is coming from different trials that we have been seeing in the last few years. It's been really astonishing to see where is the difference in terms of remission duration. You can see here in these studies, with this bar is the stop of induction. Here is the MMO20 study, RD versus MPT. You give treatment in the free arms, then you stop treatment, you give a continuous treatment in one arm, and this is the difference. And the difference is getting greater and greater with time. This was the previous study, and more or less the story is exactly the same. Here you stop induction, and when you stop induction, here is the outcome. But if you give a continuous treatment, this is the other outcome. Once again, in the bortezomib paradigm, here with a very long follow-up, you give here induction, you stop, but if you give a continuous treatment, this is the difference in terms of remission duration. So in terms of remission duration, there is no question that the continuous treatment is clearly improving the progression-free survival and the duration of remission. And you can see here from this slide the magnitude of the effect. If you do a landmark analysis after induction and you get concentrated on the efficacy of continuous treatment after induction, you can see that the improvement was 19 months in one study and 13 months in the other. Also in other randomized trials, more or less this is the same story. The continuous treatment prolongs the remission duration between 12 months to 18 months. So a major improvement. We have been using to see a better treatment of 3 to 4 months. Now we are facing a better treatment that is from 1 year to 1 year and a half. Then the question becomes, well, I'm giving a continuous treatment, I'm selecting a resistant clone, so after that my relapse will be a nightmare. It's actually not so true, because if you look at, this is a meta-analysis, the real emergence of resistant clone on a general population is not so evident. This is a study, is a meta-analysis of available randomized studies of maintenance versus no maintenance for a total of 1,200 patients included. And you can see here, when you put together both lenalidomide and bortezomib continuous treatment, you can see here that in terms of PFS1, the advantage is important, once again, between 16 to 32 months. But when you evaluate the PFS2, and PFS2 means time from diagnosis not to first relapse, to second relapse. So you put together the first and the second remission to evaluate if the second remission is so short to cancel the advantage of the first remission. Once again, in this meta-analysis, the difference is around the 15 months, even when you take in consideration the second remission. And also, in terms of overall survival, you can see here an advantage with around 30% reduction risk of death and a significance, and a statistical significance. But here is the questions, and here is coming back to the MRD story. What about if the patient is in CR? Is something changing? Actually, no. And actually, the need of continuous treatment is even more pronounced in this subset of patients. You can see here, when you look in this meta-analysis, from the PFS1, these are all patients in CR, the difference is even more pronounced. Even for the PFS2, there is even a major difference between continuous treatment and fixed duration of therapy. And once again, there is a difference in terms of overall survival. And here, the reduced risk of death is 50%. Was 30% before, is growing to 50%, which is the message that is coming. Of course, here we are facing a more sensitive disease. So a treatment in a sensitive disease is much more effective than in a resistant disease. I think this, outside the debate, is another important message. In a high-risk, resistant patient, doesn't matter what we do, we might improve the outcome of 6 months. In a standard risk with sensitive disease, more treatment improves outcome of 5 years. That's the difference between the high risk and the standard risk patient. And that's why today we should be much more concerned on the standard risk patient in comparison to the high risk patient, because it's in the standard good prognosis patient that we can really change the prognosis. And from that point of view, undertreat those patients is, in my opinion, a clinical mistake. You can see here from another study where we compare even in terms of overall survival. These are all patients in CR, continuous treatment versus fixed duration of treatment. Major difference. You don't see the same difference in patients who are not in CR after induction between maintenance or no maintenance. So once again, showing that even more in the good prognosis, in patients who achieve CR, there is a clear signal of efficacy for the continuous treatment. So why this has been already shown? The point is very simple. CR is not a CR in myeloma. You can see here those patients, those are all immunofixation negative CR. But in one instance, you have plenty of residual disease. In the other instance, there is much less disease. And this is translated in a clear difference in terms of outcome. So which is the problem? When we do see a CR patient, we do always have residual disease. And on top of that, we do face a sensitive tumor, and that's the reason why it's so important to keep treating on this type of patient. And this has been shown already, but to give you an idea of what we face with myeloma. With serum tools, we are able to see a level of 10 to minus 2 plasma cells. Even with immunophenotypic, PCR, next generation sequence, whatsoever you are using today, to the best you go to 10 to minus 6. Cure is around 7, 8, 9. So we do not have a biomarker of cure that is clearly telling us, should I stop treatment because I've cured a patient, yes or no? Unfortunately, we do not have yet a biomarker that is telling us that we are facing a cured patient and no residual disease is there. Unfortunately, there is, in the majority of patients, residual disease. But there is also another confounding issue that is, we do not know yet how much important, but certainly of relevance. Myeloma might be as lymphoma. So we might have a negative bone marrow, but we might have a localization outside the bone marrow, exactly as it happens in lymphoma. And from that point of view, the clear definition of a negativity becomes even more complicated. To close the last issue, especially with lenalidomide, but probably is getting even more important with the use of proteasome inhibitors as continuous treatment. The continuous treatment is in the reality increase the response. You can see here between stopping after 12 months of keep going up to 24, 30 months, the proportion of CR is almost double. So that's certainly a message, the evidence of the need of the continuous treatment, because it's not only controlling the residual disease, but is probably also increasing the magnitude of cytoreduction. So these are my conclusion, and the conclusion is the usual. Residual disease is always present in myeloma. Continuous therapy is clearly increasing CR rate and prolonging progression-free survival, and to less extent overall survival, but I would say in the majority of studies is also prolonging overall survival. We already had, and I thank you for the questions, what I wanted to highlight, we have to face the toxicities, and this is clearly a good reason, provided we are not adding toxicity to our patient. I'm stopping here, and thank you for the attention.
All right, so thank you so much for that, Antonio. I saw Vincent studying your PFS and overall survivor calls very closely, and so I'll see what he has to say about that.
I was actually not studying his curves. I was wondering why he's showing so many PFS curves. You know, I just want to make the point at the outset, I do not believe PFS is a good endpoint for maintenance therapy in myeloma, because it is not a surrogate for clinical benefit. It has not been a consistent surrogate. Clinical benefit is when you prolong overall survival or you improve patients' quality of life. And that has to be shown. PFS does improve quality of life for the physicians, for other people, but I don't think that there is enough data that it actually improves quality of life for the patients. Before, see, I was assigned these debates. They told me no for smoldering, no for continuous therapy, and before you label me Dr. No, I do treat patients with somewhat continuous therapy if they have intermediate or high-risk disease, because these patients have an overall survival of much less than the standard risk patients, and we know what happens when you stop therapy. it comes back very quickly. It's not a 2-year PFS that they get. So it's almost pointless to just stop therapy and then have the disease come back within 3 or 4 months. And we have data now that there might be improvement in overall survival for patients with intermediate and high-risk disease. And so I'm very happy to consider maintenance therapy for intermediate and high-risk disease. This patient, though, is a patient with standard risk disease. And the question for this patient is, should you give maintenance therapy or continuous therapy? And we have debated the role of lenalidomide post-transplant, and I don't want to debate this again. But we've seen in the lenalidomide post-transplant studies that there is survival benefit in only 1 of the 3 trials, and 2 of the 3 trials had an increased risk of second cancer. What about non-transplant regimens? That's what we're talking about right now. And the 2 triplets that have shown a survival benefit compared to melphalan prednisone are shown here, MPT and VMP. These have been shown to improve overall survival, not just PFS, in randomized trials compared to melphalan and prednisone. Question is, once you've done with the 1 year, 1.5 years of therapy that these trials used, should we do some extra treatment after that in patients who are not eligible for transplant? Using the metric that is there data from randomized trials of clinical benefit in such things? And clinical benefit, as I said, defined as an improvement in overall survival or an improvement in patient-reported outcome, which is the quality of life. The answer is, let's examine the data that's out there. The first trial that I will look at is the VT versus VP trial that followed triplets. They gave a triplet induction for a year or so, and then randomized patients to bortezomib thalidomide versus bortezomib prednisone. This trial did not show overall survival benefit, but the most important thing is this trial did not ask the question, is maintenance useful, because it had maintenance in both arms. So you cannot use this trial to really decide whether maintenance therapy is improving overall survival or not. The second trial is Dr. Palumbo's trial, which is MP versus MPR versus MPRR. And here you can see MPR by itself is not a great regimen because the progression-free survival, let alone overall survival, is not better than melphalan prednisone. So the addition of lenalidomide did not help at all. However, if you look at overall survival, there is no difference, even though the progression-free survival looks quite a bit different. So I cannot use this to decide that a year of therapy with a triplet followed by maintenance is necessary because there is no survival benefit. So I would say this trial cannot be used to answer this question either. What about the VMPT versus VT trial? This one looked at one arm which got 4-drug combination followed by bortezomib thalidomide maintenance versus a 3-drug regimen, VMP. It showed an improvement in progression-free survival, and it showed a significant improvement in overall survival as well. However, this trial is again very difficult for me to use to answer the question because I do not know whether the survival benefit came because they used 4 drugs for the induction versus 3 in the other arm, or did it come as a result of the extra maintenance? If so, is it bortezomib, thalidomide, or both? Are we planning on giving bortezomib plus lenalidomide to all our patients as soon as they finish a triplet? The final trial that we can examine is the first trial. This first trial was presented as a plenary presentation last year, published in the New England Journal of Medicine. What did we learn from this? Comparing MPT to lenalidomide given for 18 months, and you compare lenalidomide given till progression, there is a huge progression-free survival advantage. However, this does not translate into a survival benefit if you compare the Lendex given for 18 versus Lendex given for till progression. So if you just compare Lendex given for 18 months and stop, and then give it all the way over and over again, and there is no overall survival difference, and there is an abstract this year at ASH, as at least the printed abstract, shows that neither in patients less than 75, nor in patients over the age of 75, is there a survival improvement with Lendex continuous versus stopping. Having said that, I think it's still reasonable to give Lendex continuously because the time to progression, if you give 18 months and stop, is only 2 more months. So if you plan on using Lendex as your initial therapy, and you stop after 18 months, you will be restarting 2 months after stopping. So for that reason, it makes sense. But that study doesn't tell us about the triplet regimens that we usually use in the non-transplant patients. So it's unclear from here whether continuous therapy is needed. I think if our patient, a bortezomib-based triplet patient, there's really no data that I know of that shows that overall survival is prolonged by giving continuous therapy. There is no data even with Lendex. However, because of the fact that you would be restarting therapy so soon, I'm okay with giving continuous Lendex. The caveats here are that very few countries and very few people are going to be able to afford continuous Lendex for patients. You're talking about years of therapy. Standard risk patients, guys, they have a 7 to 10 year median survival. Continuous therapy year after year after year, forever, will make them live for myeloma. That is all their life's going to be about. Whereas we want our patients to live with myeloma. So we need more data before recommending continuous, indefinite 10 years of therapy for our patients. Thank you.
Okay. So the gauntlet is thrown, Antonio. So do you want to make some comment first, or do we have some comment from the audience?
I'm so happy because, you know, Vincent was definitely against continuous treatment last year. This year started to say that. He's giving maintenance in high risk. He's giving maintenance in intermediate risk. He's giving maintenance in standard risk receiving lenalidomide dexamethasone. Is only stopping if standard risk receive bortezomib. So we win for 85% versus 18%.
All right.
That is an excellent summary of my position.
All right. You're so quiet today in here.
Jet lag.
Yeah. Anyone else like to comment about this? I think that. No? Ola? No. So do you agree with Antonio's summary?
Yeah, I agree with Antonio's summary. I think he summarized, was it 85% of agreement between the two? So,
Yes.
Yeah, I agree with that.
All right.
No, to make another, probably is also true that today the still open question for continuous treatment is if, as has been pointed out before, should be given for 6 to 7 years or eventually being stopped after 2 to 3 years. So to have a continuous treatment that is not really until progression or as an early stop. I think that's probably today one of the major open questions, but certainly I think the consensus of continuous is probably.
So you're saying that it's continuous till 3 years, maybe, or?
That's balancing the issue of toxicities should be, I think is an open question. There are ongoing studies, and I think to really see the results of those studies. I will not, point it out for A versus B. I don't know, honestly.
All right. Vincent?
Antonio, we agree 85% doesn't mean that 85% of patients should get continuous therapy. What I mean is that in many, many places, many countries, economics play an important role. If you use a bortezomib-based triplet, it could be bortezomib Lendex, bortezomib cyclodex, bortezomib melphalan-prednisone. There is no evidence that overall survival is prolonged by giving further maintenance after 18 months. And choosing such a regimen would save money and without compromising overall survival. Until we show that maintenance therapy prolongs survival or quality of life, you need to at least say that that is an option in addition to the fact that you could, if you want, and you wanted to spend it, or for some reason you wanted to give oral therapy and it's preferable, I probably would prefer oral therapy, then you can give Lendex and you can give it continuously. But people need to know that they do have the choice. You can give Lendex continuously for your elderly patients. if you can afford it, and if that's what they want. Or you can give a triplet with a bortezomib-containing regimen for 18 months and stop, and maybe that's what they would prefer, either for economic reasons, toxicity reasons, or for, you know.
We have to question. I have just a very short.
Okay, we have
I
questions here.
completely
Please.
agree on the cost-efficacy issue.
All right.
Not so much on survival because there are data, but I don't want to. Please.
Okay, so let's go to my right first.
You don't have any concern on the maintenance with the emerging of resistant clone, that you're suppressing the microenvironment for long and produce more chance for more resistant clone to come up later on, that more resistant for new therapy?
So Antonio said that he...
No, that's why we show the PFS2 data, because on the 1,200 patients randomized to maintenance versus fixed period of treatment, the time from diagnosis to second relapse, okay, has a difference of 15 months that is identical to the time from diagnosis to first relapse. So you don't see in the second relapse a major shortening of the second remission.
But overall survival is going to be different? We don't know.
Overall survival in that meta-analysis, and this is the discussion with my friend Vincent, there was an advantage in overall survival too. So you see not all the data, but I do agree with Vincent that some studies do not show overall survival benefit.
Thank you.
All right. Let's go to this mic. Go ahead.
If I had Lebanon. Question, Dr. Palumbo, about exactly this PFS2 that showed it's better on patient receiving maintenance. Was there a role for switching agents? Those patients on maintenance now progressing are receiving different class of medication? Or was this European studies?
It was European study, no.
Or is bortezomib or something, both arms use the same kind of salvage therapy?
Well, of course, the salvage therapy is not so well controlled in those studies. I would say that no, there was two-thirds received lenalidomide maintenance, one-third received bortezomib, actually for 2 years, not until progression, at least in that study. And that's the data we have.
All right.
Because, all right.
Yeah.
I'm wondering if this is a binary solution, or can we have an intermediate solution where you just reduce the dosage to manage the toxicities while you're still having some efficacy?
It's a complicated issue because, of course, more is better if it's tolerated, and less is probably reducing the efficacy. So to find the right balance is not so easy. My usual comment is every time there is a toxicity is a good reason to reduce and stop. So from my point of view, I'm not taking on board any major toxicity. If there are toxicity, I'm becoming immediately a fixed duration treatment physician.
All right.
I think you bring up a very good point, and I think some of the answer lies in the randomized trials itself. You can wish to give them continuous therapy for 10 years for all you want, but the truth is that the vast majority of the patients get off therapy after 2 or 3 years, whatever you intend to do.
Right. All right. Thank you very much. Okay, so we are going to ask the question one more time about continuing or stopping for this particular patient. So just to remind you, this is a patient who responded, went into a complete remission, and then was on maintenance with lenalidomide, in this case, for 1 year. Complete remission, and so would you continue or stop, or are you unsure? Okay. Oh, there we go. Thank you. Okay, so, oh my goodness. Again, you have very, the thing that's fixed here is your opinions, apparently. Not much change. A slight drop in those of you who were unsure, but otherwise about the same. All right, what can we say here? Thank you for that. So we're going to continue forward. All right, so the final topic is an important one about how to handle salvage therapy at the point of relapse. And increasingly this is an issue as we have patients living longer and are going through different periods of relapse. So how should we handle this in an intensive fashion or in some other different kind of fashion? So the question here is a patient who has gone through several therapies. As you'll see, a 68-year-old woman. Initial FISH studies showed a 414 translocation, so intermediate risk based on that 414. The patient 2 years previously had received induction with the Cybor-D regimen, followed by a transplant, and then was on maintenance therapy with Velcade every 2 weeks for 1 year, presumably because of that 414 translocation, but relapsed despite that and was switched over to lenalidomide and Dex, so had been exposed to both bortezomib and lenalidomide. After responding again for a few months with the lenalidomide, the M protein was rising again, increasing from 0.5 to 1.5, so certainly a biochemical relapse. Looking at the CRAB criteria, the patient did develop some anemia with a drop in the hemoglobin by 2 grams to 10 grams. No bone lesions, no calcium abnormality or creatinine. Repeat cytogenetic analysis showed nothing new. So a relapse with the development of anemia, how would you handle such a patient? So would you proceed to some triple combination? And we give an example here of carfilzomib pomalidomide dex, which is available now. A doublet of some sort with carfilzomib or pomalidomide possibly, or another option of your choice. Would you consider a second transplant, or are you unsure? All right, well, I'm glad we solved that one. So very, very evenly split. So for our debaters on this topic, this is a good starting point to see if you can push our audience towards any one of these answers, except unsure. I don't want you pushing them towards unsure. So Ashaji, would you like to start us off saying that the therapy should be intensive? Please welcome Dr. Kumar again.
Thanks, Brian, and good afternoon again. Unlike Dr. Rajkumar, at least I got to say yes to one of the questions instead of saying no to both. And in fact, I would like to say yes, yes, and yes. So I would say, even though all the questions that we are asking today are important, this probably is the most common question that you face in your day-to-day practice. You have the relapsed patient sitting in front of you, and you are going over the different treatment options, and it always comes up, should we be using combinations or should we be using one drug at a time? And I think it's a problem that is only going to continue to increase as the survival of patients with myeloma is increasing, as shown here. And right now, I can estimate there are over 100,000 patients with relapsed disease that is in the community. Now, the answer to this question has to be considered in the context of what happens to these patients when the disease relapses. On the left-hand side is a study that we did in the International Myeloma Working Group where we looked at the outcomes at the point of their first relapse. And this is again data from a few years ago. You can see that the progression-free survival from the first relapse was about 3 years, and the overall survival was about 3 years, and the progression-free survival was about 13 months. On the right-hand side is a few years later. You can say basically these patients have already been treated with an IMiD, have been treated with at least one proteasome inhibitor, and now you see that these patients have a progression-free survival of 5 months and an overall survival that's only 9 months. So a lot has changed between here, and what happened, and I think that is very important in deciding how we treat these patients. Now this is again data from the same study, which you can clearly see that as patients go through different lines of therapy, they are getting less and less of a response rate, showing that the clones are getting resistant to therapy. Not only are they getting lower response rate, the responses that they get are actually lasting lesser and lesser. Now, why does this happen? And I think a lot of the genomic studies that have been done in the past few years have shed light on what is happening to this disease over the courses of different therapies. On the left-hand side is again a study from the MMRC, which clearly shows that the patients with multiple myeloma have increasing numbers of subclonal population. And on the right-hand side is again another representation from the same study, looking at the most common 11 genetic mutations that we see in these patients. And you can see that the proportion of cells that carry these mutations actually increase when you're looking at patients who have relapsed after prior therapy compared to when you look at them at newly diagnosed phase. So there's clearly increasing clonal heterogeneity as patients go through multiple therapies and undergo relapses. And there is this whole concept of clonal evolution and emergence of new clones as the disease continues to progress. Obviously, there is a first hit, then there is a progenitor cell that eventually becomes cancerous. And when you treat them and they relapse subsequently, either the same clone can come back, or it can undergo evolution to a different clone, or maybe even some of the earlier progenitor clones actually may evolve into another myeloma clone. And this kind of evolution over the disease relapse is particularly evident in patients with high-risk disease. As you can see in the lower picture here, where on the right-hand side you can see patients with high-risk disease has increasing numbers of copy number abnormalities, which is much more striking than what you would see in patients with standard risk disease. What is also very striking is some of the very elegant work that have been done by our colleagues, which shows that at the beginning you have multiple clones. You give them a particular therapy. In this example, it's lenalidomide dexamethasone, and you have a remission stage. We still have a clonal spread in these patients. When they finally relapse, there's a small clone that was shown here in green, which has become the major clone right now. You treat them with a different drug, and you see that one of these other clones is now starting to increase in size at the time of relapse. And eventually, you see that this patient has developed plasma cell leukemia, and the major clone is something that was not very evident in the beginning. So clearly, there's evolution of this clone that is happening as the disease is treated with different agents, and which clone kind of comes back at the time of relapse to some extent is dependent on what drug we are using to treat them. So how do we put that information into perspective, and how do we use that information to decide how we treat these patients? Let's take a look at this phase 3 trial that was done by the French group, where they actually randomized patients at the time of relapse from the stem cell transplant to receive thalidomide dexamethasone with or without bortezomib. And they were able to show that the triplet drug combination resulted in an improved progression-free survival, and there was a trend towards improved overall survival as well with the triplet. So clearly showing that the patients are benefiting by getting the triplet regimen. Now let's take a look at some of the more recent drugs that we have available in our armamentarium. So this is a phase 2 trial that was again presented last year of carfilzomib, pomalidomide, and dexamethasone. And you can see that in a group of patients that were very heavily pretreated, were refractory to bortezomib and lenalidomide in a substantial proportion, the combination of carfilzomib and pomalidomide led to a PFS of 9.7 months, far superior to the 5 months we saw in the historical controls, and an overall survival that had not been reached at 18 months compared to an overall survival of 9 months we saw in the historical control population. So this makes very strong argument for using combination therapies in patients with relapsed disease. Now it's not only a question of just increasing the efficacy, we can actually recapture some of the sensitivity to the drugs that we have already used. A good example is the data from Dr. Richardson, where patients who were refractory to bortezomib were actually treated with a combination of panabinostat, a HDAC inhibitor, and bortezomib. And you can see that a good number of patients actually did get a response to the combination, suggesting that we can recapture some of those sensitivity to a drug by using it in combination. And the subsequent phase 3 trial also showed that there was an improvement in the progression-free survival when you use the combination of panabinostat and bortezomib. Now, there's also clear instances where there's synergy, where the 1 + 1 is more than 2. And a good example is the combination of elotuzumab with Revlimid and dexamethasone. And you can see the elotuzumab as a single agent is not associated with any significant degree of anti-myeloma activity. However, in a group of patients who are relatively lenalidomide naive, you can see that they were treated with a combination of elotuzumab and lenalidomide. You actually get a very high overall response rate, almost comparable or better than what you would get with lenalidomide in the upfront setting, including some very deep responses of almost 64% of patients getting a very good partial response or better. So clearly, there is one more argument for using combinations which are clearly synergistic in our studies. So I think I would like to summarize by saying that relapse actually tells you there is a clonal evolution, there is a clonally heterogeneous population of myeloma cells in that patient, and these patients clearly have to be treated with combinations with different mechanism of action, so you can simultaneously target the different clones in the disease. Combinations also allow us to use drugs that have been used before, and we can recapture the sensitivity to those drugs. We can also use combinations to actually capitalize on the synergy that we see when we combine some of the drugs. And I think by using very effective therapy right in the beginning in these relapsed patient populations, I would argue we can actually improve their early mortality as well. But most importantly, I want to quote Dr. Langren, who completely agrees with me. He says we should use combination therapies in patients with smoldering myeloma. And if we were to use combinations in smoldering myeloma, I think the answer for the relapsed patients is very evident. Thank you.
All right, so combinations are the way to go, Ola. Is this true?
So thank you very much again for giving me an opportunity to present here. So I want you to pay particular attention to the topic. Is intense salvage therapy the preferred approach in relapsed refractory myeloma? And I have again been given no, but what I would like you to look at is the second word, intense, because I think the word intense historically was integrated with the word effective, but I do think in the future that may not be the case. So here is the structure of this presentation. Do nothing, do intense, effective, and the third one is to do non-intense, but still effective. So do nothing, that will not work. So I'm not going to go there. So that's not where I was going, because the topic was not intense therapy being better. Or actually, that's not what I'm going to argue for. I'm going to argue for effective, non-intense. That was what I was asked to do. So that's what I'm going to talk about. So is there a preferred infusional regimen for patients with relapsed refractory multiple myeloma? There was a study submitted to this meeting that is going to be presented by the group from Moffitt, and we have heard and we have seen many presentations at other meetings. There are a lot of papers in the literature, and Dr. Kumar was mentioning some of these studies. But for the purpose of this meeting, I picked this study that is being presented here at the meeting in San Francisco. It's a retrospective analysis of the 3 most commonly used myeloma salvage therapies that do belong to this category of intense treatment options. And it comes from the Moffitt Cancer Database. So they are DCEP therapy, VTD PACE, or CVAD. So what I think is interesting here is that this study illustrates what many of us have seen in the clinic for many years. There are many patients, and they have been treated with multiple prior lines of therapy. As you can see, highlighted in red, the average number is around 3, And in the middle here, you see it goes all the way up to 13 prior lines, but it ranges from 1 to very many lines. So this is, I think, very representative of what we are facing in reality, in the real clinical setting. So as you see on the very top, you have DCEP, you have the VTD PACE, and you have the CVAD therapies. And what I want to convey with my presentation today is really what we kind of know, but I do think we kind of almost, I don't know if we forget it, but we kind of don't really want to think about it when we are standing there with the patient and the relapse is the reality. We give this therapy, we know it's very spicy, but we kind of know that it's probably not going to work. And that's what this slide shows here in red. You see the median time for progression-free survival is only 3.4, 4.5, and 5.7 months. All these patients have been treated heavily before. They have multiple relapses. It's not going to last for a very, very long time. And what's striking here is when you compare all these different strategies, and the one in the middle is, I think, probably the most spicy, it's not better. It's just a lot of toxicity. So for that reason, I would argue for the non-intense, which is what I was given today as a topic to talk about. No to intense, but again, effective therapy. And I think Dr. Kumar has already been paved the way for me for this presentation, and he talked about the new combinations of drugs. This study, the MM003 study, randomized phase 3 trial, that was presented at last ASH with pomalidomide dexamethasone versus dexamethasone alone, of course shows that the combination is better. And we had PFS with hazard ratio of 0.5 and overall survival, the hazard ratio was 0.7, and they were both significant. So this is the kind of the first step into what I really want to convey, which is this study. I think this study is a turning point in treating relapsed myeloma. This is, in my opinion, an example of how you can deliver a very effective non-intense therapy using carfilzomib, lenalidomide, dexamethasone versus lenalidomide, dexamethasone. And Shadi already talked about these results using pomalidomide and carfilzomib dex. Dr. Stewart is going to present these data at the meeting, so I'm not going to steal all his thunder. I think it's a very important study. But they show in this study that the median overall survival is prolonged, but the progression-free survival is more than 2.5 years. So 2.5 years of progression-free survival in this study. And I think, yeah, here it is. You have 26.5 months median progression-free survival versus 17. So here's an example of a non-intense, effective combination therapy. So I agree with Dr. Kumar that using multiple drugs should be used, but they shouldn't be used in a fashion so we bombard the patient, and all we do is just cause a lot of toxicity. So my conclusion is that effective therapy does not have to be intense, and intense therapy is not always effective. In myeloma, we now have effective, non-intense therapeutic options, not only at newly diagnosed patients, but also at relapsed disease. So I do think the implications of this is that we are not going to harass people because they're relapsing and not give them effective therapy. We can use these new drugs, and we're not going to discriminate patients by age because patients that are older can also tolerate these drugs. So to summarize my presentation, is intense salvage therapy the preferred approach in relapsed refractory myeloma? And I was going to say no, because effective therapy does not have to be intense. And with that, I would like to thank you for your attention.
All right, well, thank you for that, Ola. Now, one thing that you didn't exactly touch on would be one of the non-intense approaches would be to use a doublet versus a triplet, so that pomalidomide and dex or carfilzomib and dex versus a triplet. So do you care to comment on that?
Well, I think, yeah, so of course, when we have these debates, we are given topics to argue for no and yes, so it becomes a little bit arbitrary. In the real world, of course, there are differences. So I do think that in a patient where the disease is more active when it comes back, and it has the features of more aggressive biology. I think, in my opinion, using the triplet to cool off the disease, to bring it down, would be my way of going. In a patient where the disease is less active or less aggressive, it doesn't evolve as fast, and it may not be phenotypically showing evidence of aggressive disease, I guess you could try a 2-drug combination. If that works, good. If not, you could add the 3rd drug. So I don't think that one size fits all, but if we're looking at patients where they have multiple relapses, I think we're more likely to end up in situations where the disease is going to be more aggressive. So then I probably would do 3-drug combinations.
All right.
So earlier relapses, I guess you could argue, but it's impossible, of course, to give an answer here applying to every patient. Every patient is different.
All right. Shaji, you want to respond to that, or?
First of all, I have to congratulate Dr. Langren for reducing the debate to the question whether KRD is intense or not intense. So I think I totally agree with Ola that the combination is the way to go, which is what I was trying to say. I think the bottom line is that once the patients relapse, I think the horse is out of the barn. We clearly see that these patients actually have multiple clones, they continue to evolve, and I think I look at the first relapse as the second chance to kind of redeem, and I think those patients really have to be, again, I'm not talking about VDT patient, DSEP and CVAD. Those are more like the very end stage. We're trying to control the disease transiently with the goal of maybe taking them to something like an allotransplant or something. But we are talking about using rational 3-drug combinations with multiple different mechanisms of action to control the disease.
So maybe, Vincent, you might want to comment on this. I think that one of the questions that's important for patients is that there may be a limited number of drugs that are available, and so they might want to use pomalidomide and then maybe save carfilzomib for later, but maybe that could be not so prudent. It might, to really control a relapsing disease, it might be better to combine and to get a better efficacy. What do you think about that?
Thanks, Brian. It is a very hard question because many of the trials that were done to approve these drugs, for carfilzomib was a single-agent trial. For pomalidomide is pomalidomide low-dose dex. But you can't just use that labeled dosage and the way it was approved to actually manage patients, because most of our patients right now, when they relapse, they're relapsing on a triplet like bortezomib, lendex. You try giving POM low-dose dex to that patient, they will progress within 1 month. Similarly, if you gave single-agent carfilzomib, you will basically lose the value of these drugs. So I think I agree with Shaji. I think when you get a relapse like this, it's just so important to get the disease under control quickly. Otherwise, you will deny the patient the opportunity of having a lasting remission. So in this one instance, I think we have to vary from the label and go with a triplet like, I think, for example, in this patient, carfilzomib lendex or carfilzomib pomdex, if you really want to get the 8 to 12 months of PFS that you might get with that.
Right. Okay. Any other comments? Antonio?
No, I would agree that certainly if feasible today, there are evidence that the 3-drug combination may be better than a 2-drug combination. So from that point of view, I would completely agree.
To what extent, for example, in Europe, is that feasible? I mean, that might not be always possible, though, right?
For us, things are much more easier because our prescription is totally bound from the regulators and the reimbursement. So we do not decide what we want to do. We give what is allowed to give. So the story is completely different. And our ability to give a 3-drug combination at relapse is fairly limited. But beside that, from a clinical point of view, I would totally agree with Vincent.
All right. So do we have any other thoughts or comments from anyone here?
There is a question. There is a question.
Oh, yes. Sorry. Please go ahead.
Dr. Jerry, you've actually just opened a door that I was kind of interested in, which is there's clearly an aspect of patient choice in a lot of this, both this case and the prior case. And I was curious what the panel felt were important issues in making sure that the patients really understood in coming to these decisions with their doctors.
Right. We touched on that a little bit with this last comment from Vincent about explaining what might happen with using one drug and then another drug or combining them together. So how important is that discussion with the patient, would you say?
No, I think it's like critically important because for many, many decisions we make, we are not sure which answer is correct. Is the patient actually going to live longer because I make choice A or B is actually unclear in many, many clinical decisions we make. And so when you're unclear about that, it's better not to be dogmatic that my way is the right way, but ask the patient what would they prefer? What do they want out of life? Some patients, preservation of hair is the most important thing. For some patients, being able to continue with their daily work is more important than having even an extra month longer of remission. I mean, you just have to take these things into account because it's easy to say carfilzomib Lendex, but you're talking about a patient having to go to the hospital Monday, Tuesday, every week. And some people may not want that at that point in their life.
Right. Very important. Thank you for that. Question here in the middle.
Felix Scheswell from Norway. I was just wondering, when you have used pomalidomide and carfilzomib and everything is lost from novel drugs, do you still see a role for VTD PACE and DSAP, CVAD? Do they have a role, or is it other patients generally too treated to tolerate those regimes then?
Yeah, so I think a very important question. Do we still use DT PACE and some of those regimens? I think the answer is yes, but in a certain setting. So do you want to comment on that,
Sure.
Shadi?
No, I think those regimens clearly, they're very effective and have a clear role to play. But I look at them as a bridge to something else instead of just a bridge to nowhere. Yeah. I think we really have to have a plan to how we're going to follow up that patients after a couple cycles of VDT PACE. Most patients cannot take more than at that stage in their disease, more than a couple cycles of those intense regimens. So unless you have a plan, whether it's a second autologous stem cell transplant or an allogeneic transplant or something along those lines, I don't think we should offer that as an option.
Okay. So
I do use VDT PACE quite often. I mean, not just with a plan for auto or allo, but in very aggressive relapses, 1 or 2 cycles, and then you can go to a milder regimen like bortezomib cyclodex or carfilzomib Lendex or something like that. But there is a role. I mean, clearly these drugs work, and they've saved so many patients. I mean, it's very hard for us to talk here because the data are so limited. If you just did a PubMed search on VDT PACE for relapse, but personal experience is that it's very, very helpful in selected patients in getting them to some other regimen that they can tolerate or to a transplant.
yeah. So certainly cyto reduction is a high likelihood, but for a short time. Yeah. Ola?
Yeah, I agree with that. So what I was saying, that not using these spicy therapies, I was thinking, I wanted to communicate that in a broader context. So I think having access to non-intense effective therapy is more of kind of a broader application. But I agree with what Vincent says, that for individual patients, but the disease is very aggressive and you have the intent to go to another approach, I would also use the VTD PACE, absolutely.
Thank you.
All right. Maybe a final point, we see more patients who maybe have not had a transplant at this point of relapse. So how do you view the use of transplant in this setting in patients who maybe have not had one? You want to comment on that?
So I think there's increasingly, and if you look at the CABMTR data, there's increasing use of second autologous stem cell transplantation as salvage. And I think when you talk about salvage transplant, it could be a second auto transplant after relapse from the first one. And in those group of patients, especially those who had at least an 18-month progression-free survival from the first transplant, there's clearly a role in using a second autologous stem cell transplant as salvage with very reasonable outcomes. And clearly there's increasing trend of patients, especially in some of the context of clinical trials, of delaying the stem cell transplant. And those patients, there's no question about it. The high-dose therapy should be considered at the time of the first relapse if we didn't use it as an upfront therapy.
I agree with only, certainly the rule is that autologous transplant can be reused if the remission is at least 2 to 3 years. Is an excellent way we use it very much to have a profound cytoreduction in a faster way, even with reduced intensity melphalan. It's a very simple way. If you have some stem cell in the fridge already, to use it 8 milligrams per square meter, 120, just to have a very fast cytoreduction. Doesn't last. That's at least is my experience. So you need also over there a sort of continuous treatment, because especially at relapse, the remission are pretty short. But on the other hand, is an excellent way to have a fast cytoreduction.
Okay. Any other questions? If not, we'll go and ask this final question again and see what you think now. See, we had a pretty even split, so see if we moved you not towards unsure, but maybe in one direction or another. So this was a patient with a 414 translocation, so intermediate risk, CyBOR-D and a transplant, and then maintained on Velcade, relapse, switched to Revlimid, and then with an early relapse, but with an increase in M component and development of some anemia. And so the question was, would you use a triplet, a doublet, consider a second transplant that we just touched on here a moment ago, or would you be perhaps unsure? What do you think now? We don't mention whether the triplet is intense or not. Okay. All right. So we did have some movement here.
Non-intense.
Toward the non-intense triplet, you think, maybe? Yeah, but definitely some movement towards the triplet therapy. So I think that that is an important point. And some reduction in the unsure. Virtually nobody's unsure anymore. So that's good. So that's a good result. So. All right. Well, that actually is the end of the planned session. We are available for open Q&A at the end here. You have been so quiet during the session. I don't know if you have any questions that are lingering at the end, but we're definitely happy to answer those if you have any. But if not, I would thank you all for being here. We hope that you enjoyed it and found it worthwhile. Thank you for being here. Thank you.